Dylan is a conscientious, committed, and always, or 99.999%, so nearly always, good-natured professional with whom I thoroughly enjoyed working while I was at the New Mexico Department of Health. He has become a good personal friend as well as a professional friend. Dylan serves as the New Mexico Department of Health's designated mental health epidemiologist, and he's worked with NMDOH for the past several years. He is one of a few state epidemiologists in the US whose role is solely focused on tracking and analyzing state and national mental health issues and trends, and does this with the public health framework. New Mexico is fortunate to have his skills and expertise to help us understand the current state of mental health across the lifespan in our state. Toward this end, he'll be sharing results from state of New Mexico surveys and other information which give voice to the actual experiences and feelings of our fellow New Mexico residents. Dylan is a New Mexico native who earned a master's in social work, a master's in public health from New Mexico State University. He has an extensive background in child welfare, residential treatment, case management, assertive community treatment, and supportive mental health housing. Thus, he brings a wealth of practical knowledge to tonight's discussion about the current state of mental health across the lifespan in New Mexico and why this information is important and notable. Dylan's credentials and experience underscore his commitment to advancing understanding and support of the mental health of people living in our state, both important aspects of NAMI's mission. We are honored to have him present to us tonight and confident that you'll find the information and professional insights he shares informative and enlightening. So please welcome me in welcoming Dylan.
That was incredibly kind, Jackie. Probably the nicest intro I'll probably ever get. So I really, really appreciate that. Thank you so much. Also, just off the bat, I'm going to share slides, but I wanted to acknowledge that I really thought it was important and special that you all invited me to talk, because NAMI has been personally helpful in my life, and I think in particular to my partner's life in direct ways. So I just really value your organization and the work you all do. I just think it's so important. So give me a moment while I put up my slides, and then I'll probably pull the chat open. And I'm going to press enter in the chat just to put my name and contact information in case people need it for anything in the future. Oh, any other housekeeping? I would say Jackie has a good plan there for questions. If people put questions in the chat that relate to things I mention or say, I'll try to follow them. I'll definitely catch them at the end, but sometimes if it's related to a slide, it is helpful to see it so that we can just bring it up and talk about it while we're looking at the same thing. But if not, no worries, we'll catch each other later. So my role at the Department of Health as an epidemiologist is to look at data sets basically to produce health statistics related to mental health. So I look at things like death data and surveys of adults and youth. I can definitely share my slides if there's a way for them to be sent with everybody. I'm happy to share these. And maybe I can put them in the chat at the end if I have a minute in a PDF form. So I do a little bit of check-ins and stuff, but kind of before we even talk about mental health, I like to kind of do a primer to get people thinking about health in the way that, say, a Department of Health wants to think about it as a public health issue. So just to think about framing us, getting used to thinking about public health, if you could maybe put in the chat some answers to this question. It is not a trick question. I'm just looking for obvious answers here. What do we do to prevent oral health issues? Oral health is our teeth, so tooth decay, gum disease, tooth loss, infections. If you're a brave soul and willing to type in the chat, just what kinds of things can we do to prevent cavities and tooth issues? Things you do. I know it takes a second to type, so I'll give a moment. Oh, wow, there's some, oh yeah, floss. There's people here floss. Not everyone flosses, but it's good if you do. Mouthwash, brush teeth, checkups. Yeah, you all are winning. You're passing the test. Education, absolutely. So in public health, if you go to a public health class, you'll probably see some version of this type of prevention slide. There are 3 levels of prevention. So there's primary prevention. Those are things that we recommend everybody do, and education information we provide to all people who are at risk of a health outcome. So that's where we see like brushing teeth, teaching young people about how sugar and other foods can impact gum disease or health, teaching about flossing. Secondary prevention is things we can do to help people with health stuff before or as symptoms early arise. So that's the checkups. I thought a bunch of people mentioning seeing doctors and checkups with doctors. If you see a dentist when you're just beginning to have like teeth issues, then maybe you can get a filling and it doesn't become like a major infection or tooth loss. We do those secondary screenings to catch that. And then tertiary prevention is the types of strategies we use for people who say have lost teeth or had a serious health issue that they now have to live with, and maybe teaching them nutrition and diet changes so they can still live comfortable lives with tooth loss or other teeth issues. And I promise this will relate to the topic, and we won't spend the whole time talking about oral health. But my follow-up question would be, what if we didn't do any of the stuff you put in the chat? What if we didn't floss or rinse our mouths or do checkups or any of those strategies? What would happen? What would our society or our individual health look like? So it's just the same as before. You can put an answer in the chat. This is a hypothetical. There are no real answers here. Yeah, people lose teeth. Probably a lot of us would be in chronic pain from tooth issues. Yeah, gum disease. Probably have like heart issues or other issues. If you're having chronic tooth pain, maybe you're not sleeping as well. Probably some mental health symptoms also. Yeah, diabetes is associated with these issues. And then healthcare costs. Yeah, we would only be paying, instead of paying for checkups, we'd only be paying for tooth removals and the most expensive and most invasive types of treatments, the ones that have the greatest harms or risks. Yeah, it would be a disaster. And so I just put this out there because I think the United States and a lot of the world is sort of dealing with this question around mental health. And I think it's helpful to bring up. I think in mental health, traditionally, a lot of public health departments and human services departments have seen dealing with mental health as an issue of providing clinical services for people with mental illness, which is an important strategy. But if it's our only strategy, and if we wait for people to have mental health issues that are like diagnosable illnesses before we respond, that really doesn't represent a comprehensive public health response. I think supporting people as children, as adults in the workplace, and developing strategies that help people navigate their mental health at all stages of life is kind of the challenge that I want to put out there. And I think people in this room will probably have a lot of insight about how we could do better at those things or what opportunities there are. So this is really just an exercise to frame some of the data and hopefully give an idea of what kinds of questions I might have for you at the end. So hopefully you have some for me. So I'm going to repeat a little bit of what Jackie said, which is I'm not going to be telling individual stories of suicide or mental health, but I will be sharing statistics related to mental health and suicide. It's okay to step out or do whatever you need to do to, listen or not listen to what you need to hear or not hear. I would also say that I'm trying to say things in a way that is true to myself and also fair to these audiences. But if I say something that you don't find quite right or feel should be said differently, please let me know. Either reach out to me by email or phone, or just say it in the meeting. I want to learn and make sure that I'm not talking in a way that increases the harms that people already have experienced. For this presentation, mental health is defined as being broader than just mental illness. We're talking about mental health that includes our emotional and psychological and social well-being, how we deal with stress, the presence of emotional wellness, and sort of how we navigate social emotional challenges and issues. You probably will see some slides that focus on illness, but the goal isn't to really just see it as that type of issue. That really isn't all mental health is. You all may know, but 988 is our 3-digit dial code for people to connect with a crisis line or call center. I think in New Mexico, you'll generally connect to somebody at the New Mexico Crisis and Access line if you call this number. But we just like to make sure people know about the 3-digit number. And you all may be familiar with it. I find with general audiences, a lot of people still don't know about this number. And I'm trying to just encourage people to know there's an alternative to 911, and also, especially for people who are new to thinking about mental health, an easy thing to remember in accessing and getting some basic supports. So just kind of, again, providing some more context to what I'll be sharing. New Mexico Department of Health collects data in a few different ways, not all of which will be shared today. One way is we share data that comes from our death records. Really, that's from when a death certificate is written for a person, that it becomes part of a data set. When you see like leading causes of death reported or the number of COVID deaths, those are usually generated from this data set. When I talk about suicide deaths, that's really where those records are coming from. So there'll be a lot of information that comes from 2 of our surveys, the Youth Risk and Resiliency Survey. We provide a survey to middle school and high school students inside classrooms across the state. It's a large survey, about 20 to 30,000 students will take the survey every other year. And we use random sampling and some scientific study design strategies in hopes of getting really a representative view of youth in New Mexico. We also conduct a telephone survey of New Mexico adults called the Behavioral Risk Factor Surveillance System. I might sometimes refer to this as BRFIS, or the other one is YRS. Our telephone survey tries to survey about 6,000 adults every year. And both of these surveys are voluntary, and they're not really necessarily mental health focused. They collect data about all sorts of health. If you see a news release about the change in obesity in America, that probably comes from the same data source. That's where they ask questions about things like this. And they're part of a broader CDC network of data collection. Lastly, I'm going to show a couple of slides that relate to our emergency room data. We do collect records about when people are visiting emergency rooms and for what reasons. And this can be helpful in particular because we can report this data in a timely way. A lot of our data is a year or 2 old by the time we share it, but we have emergency room data that's much more recent, which can be helpful in thinking about what's going on right now. So I have we call these games, they're not always the funnest, but I think it's helpful just to kind of practice getting used to thinking about numbers and thinking about comparisons, and giving permission to everyone here to own the idea of using data and talking about it. So this is, again, one where there's really no right or wrong knowledge. It's not a test of knowledge. I didn't know the answers to what this would be before I pulled these. But also to think about how visits might be different for different things. So the question I have for you all is, in New Mexico in 2023, how many emergency department visits for young people, that's kids aged 5 to 17, were there in these different topics? So I'd start with the very first topic, which is this diagnosis category called abdominal pain and other digestive abdominal signs. So that's actually like diarrhea, stomach aches, stomach pain. And the correct number for the number of kids who went to an emergency department in 2023 is on the right side. So if you're brave and willing to put just like a letter, like A, B, C, D, what letter do you think is maybe the answer to how many kids went to emergency department for that? Then we'll see if the guessers were right. But yeah, no right or wrong answers. Well, I guess there's a correct answer, but it's okay if people don't get it right away. See a couple A's, see a D. Okay, I'm seeing some room all over the place. So this one, the people who are confident at the start were, I don't know if they were particularly wise or insightful. I did not know this until I pulled this, but they're right. So a lot of kids go to emergency departments for diarrhea and stomach aches. It's a pretty common reason. When I shared this earlier, someone pointed out that a lot of these might be cross-coded with mental health visits, kids who have anxiety or stress or are reporting something, and it would be interesting to cross-tab that. I'll probably spend a little bit less time on the rest of these, but again, we're just practicing thinking about numbers. So what about anxiety and fear related disorders? Where do we think that would fall in the number of visits? Is that going to be towards the top or towards the bottom? I'll give you just a minute to type in there. Okay, we're seeing a spread here. Okay. So this one, the answer here is actually towards the bottom, about 2,000 visits involving anxiety or fear-related diagnosis that involved anxiety. Okay, what about COVID? How many young people were diagnosed with COVID in the ED? Oh, I spoiled it. So this one's actually the lowest. It's worth acknowledging that not many young people are dying from COVID, but many of them do contract it. And now what about depression and depressive disorders? Are they going to be maybe above or below anxiety? See a F, a B. It's tricky. I know it's just a wild guessing game. There were some good guessers in here. So this one, yeah, we're climbing up quite a bit. That's like the third most common issue among all of these. And then motor vehicle accidents. And as we're getting down to the final few categories, it might be a little bit easier if you can keep in track of what's available. Let's see an E. Let's see. So this one's right dead in the center. These are pretty common for young people and a major cause of injury and death for young people still. Yeah, I think Julie's particularly good at guessing what I can see. And the flu, what do we think about the flu? Is that more or less common than anxiety, depression? And I'm just going to run through these very last ones. So flu comes in the middle of the pack also. Yeah, there was an spike in flu visits this year. I'm a person who had the flu. And I'm going to run through these last two without going through the guessing. So neurodevelopmental disorders, that includes, for young people, that includes ADHD, which when I've looked at these visits, most of them involve an ADHD diagnosis. Many of them seem like they're related to a medication issue when young people are going to the ED. Not as common as other mental health categories, but for a single diagnosis has a lot of events. So there's only one category left. I don't know if people were keeping track of everything, but for suicide ideation, attempts, and self-harm, we see that there were almost 3,000 ED visits in 2023 for young people for that code. Very common, in fact, more common than a diagnosis of depression or anxiety. Doesn't mean that more young people have suicide ideation than have depression. But it means that when they're going to an ED, this is a common presenting symptom. And kind of also just to see sort of how common, oh, thank you, how common some of these issues are in comparison to other health topics. So I'm gonna leave this question floating in the air, but many people have been asking whether or not mental health is a public health crisis. Some people haven't been asking and just stating it. The US Surgeon General in 2021 issued a mental health advisory for young people, talking about urgent issues and concerns about mental health. I think actually the CDC director this year in a different report identified it as a public health crisis as well. It's kind of a subjective term what a public health crisis is, but we do know that a tremendous number of people live with mental health conditions, and many people are facing challenges with daily life and with the symptoms and experiences they have related to their mental health. I want to talk a little bit about suicide at the front and just some trends that I think are important information that people who are invested in this topic should know. There's I guess as an intro, there's this concept of death of despair. I actually personally hate the label death of despair, but there are these Nobel Prize winning authors who came up with, they did studies of like, why are certain people in the United States not living as long as they used to? They saw that the average lifespan of Americans was decreasing. And when they really digged into the research, they saw that a lot of the decrease in lifespan was due to three categories of death, that being suicide, drug overdose, and alcohol attributable deaths. And that those have been increasing year over year for several years now. One thing just I guess to point out here is that a takeaway from this is I'll be talking about mental health, but a lot of people think that it could be helpful to frame a public health response that sort of has a shared approach to these topics and doesn't see them as like siloed different topics, and recognizing that actually things like economic and well-being and social determinants of health, that's things like people's food security and housing, and sense of dignity and role in society can really impact all of these outcomes. I think I have a little note on here, but in the last 21 years, these category of deaths have increased more than 2.5 times in New Mexico, much more common causes of death. I think if they were if they were considered a leading cause of death on the standard leading cause of death chart, they would be the third leading cause of death for all New Mexicans as a combined category. But we don't usually show them combined like this. So there is a slide in here. We're going to talk a little bit about 2022 data at one point, but only for a narrow group. We do have some 2022 death data available, though. I also want to talk about New Mexico framed in context of the rest of the country. You might sometimes hear that we're the fourth highest rate of suicide death in the country. So there's a bunch of really tiny labels here. The bars at the bottom are each state in the country in 2021. That's the most recent year where CDC national data is available. And there's a couple of things to point out here. So we're number 4, we're the red bar on the left side. That green bar towards the right is actually the US average. And we're about 80% higher than the US average. But the other thing that I always find really jarring is if you compare New Mexico to, say, the state with the lowest suicide rates, being New Jersey, we have a rate that's about over 4 times higher than the lowest state suicide rate. And so when we look at disparities in the risk for health outcomes across states and other health conditions, it's not normal to see as wide a gap between the largest and smallest. You'll probably also notice that the states ahead of us, Wyoming, Montana, and Alaska, people have pointed out they share some attributes with each other and with us. They're high altitude, mountain states that have a lot of rural and open areas, and probably some cultural similarities too, which may be a clue to why they're on that side of the chart. But I don't think there's been really enough work to understand our state's context and not just frame us within the United States broadly. But I think we should try and figure that out because we don't look like everybody else all the time. Another thing I like to just point out is, so suicide is a leading cause of death when you look at all people, but really the deaths are primarily among males. For every 1 woman who dies from suicide in New Mexico, there's about 4 men who die from suicide. And so if we just look at a leading cause of death table, looking at men, it's actually the 6th leading cause of death for them in the most recent 5 years of data. That's actually ahead of stroke, diabetes, and other common health conditions. So really serious issue, and one that I think most people who look at data are fully convinced represents a major public health concern. Lastly, I think we always talk about suicide death, but really most people who think about suicide will not die of suicide. Most people who attempt suicide will not die, but that doesn't mean that people who consider suicide or attempt suicide or think about these issues aren't people of serious public health concern. Their lives and their families' lives are also affected, and I think we need to think about strategies which support people at all stages, and think of this issue as not just a mortality issue. But something like 99% of people who consider a suicide attempt will not die from one. It's just very common for people to have thoughts or consider. kind of on the topic of, is this a crisis? One thing that I think a lot of public health officials have been concerned about is that if we look at trend lines, and look across a few different data sources, we see that for many years, there was no real change in our mental health measures. I would argue that they were already too high 10 years ago in some of these. So this is a measure of how many young people aged 12 to 17 experienced a major depressive episode in the past 12 months. It's an estimate from SAMHSA. And for about 8 years of survey cycle, they found really that it went up or down a percentage point or two. But in the most recent 4 or 5 cycles of the survey, they've seen an increase in young people reporting these symptoms to a point where it really almost doubled, increased about 90%. This is from a different survey. This is from the Youth Risk Resiliency Survey. What I'm really trying to point out here is that the same sort of trend is here. Across those same years, up until about 2013 to 2015, we would see about the same percentage of young people who said they felt so sad or hopeless for at least 2 weeks or more that they stopped doing regular daily activities. About a third of students had said that 10 years ago, and now that's up to about 45%. Proportionally, this is like a 38% increase. And we're really tracking very closely to the national statistic for this one. And the last one here is just looking at, again, suicide, but there are 2 stories on this slide that I want to just focus on because I think both are as important. And really, I think should bring us back to the first questions we had at the beginning. The top is a bar of unintentional injury deaths. So for young people ages 11 to 17, unintentional injury deaths are mostly like car accidents that had killed them. This has actually dropped in half in the last 25 years. Young people are still often dying from these events, but half as often as they used to. The numbers have increased in the most recent years, but they're not anywhere close to what they used to be. I think if I could pull this chart back another 20 years, that would probably be even a more dramatic drop as things like seatbelts and other changes became a big norm there. Do any of you all have thoughts about why, say, like car accident deaths may have declined for young people in the last 25 years? Maybe just put in the chat things you know of. It's not any one thing. I mean, whenever I ask, those people usually point out things that I didn't know about. In the last presentation, someone pointed out that we have sort of like a graduated driver's permit and licensing program that may have probably also made it safer for young people to drive once that was added. But I'll give just a moment if you have any quick thoughts about things that make. So yeah, teens are driving less. Actually, that's one I haven't thought about, but it's probably true. And yeah, the less people can afford cars. They're also spending more time on computers and probably less time running around on the street. So that may also be a factor, but kind of one I hadn't thought about. Yeah, New Mexico has had a very aggressive approach to DUIs. We remain the leading state in the country for alcohol mortality, but if you just look at alcohol-involved motor vehicle accident deaths, we've actually dropped substantially in that category. Most of the alcohol-related deaths that remain are related to like chronic liver disease, alcohol poisoning, and even things like suicide are sometimes attributed to alcohol in those counts. But yeah, those are some of the things. And so I guess the point here is that communities and states working in concert over decades can make year-over-year changes that can actually meaningfully change these trends. I think sometimes it feels hard or impossible, but the proof is here. We can see it. And I probably need to add an annotated one at some point where you can actually see what happened year by year. So the other line here is suicide among youth aged 11 to 17. Excuse me. Kind of like the previous charts, for many years, young people had a similar rate of suicide. And in fact, it looked like it may have been decreasing for some years leading into 2015, 2016. But in the most recent 10 years of data, 8 years of data, we've seen this number increase about 66%. And it became the leading cause of death for youth aged 11 to 17 a few years ago. Yeah, those are some interesting economic factors you all put in the chat related to the decrease in driving incidents that I hadn't thought of before. I like that. You're probably right. So someone asked about 2022 in the most recent year of data. We have a finished death file, but there's still some work to be done with um, preparing our final results to share in like regular reports. Among young people, there was a decline in 2022 of suicide deaths, excuse me, which was the second year in a row. So even though that trend had gone up and up for many years, we now have 2 years of declining youth suicide events. In fact, 2022's youth suicide rate was half of what it was a couple years earlier. I do want to caveat that we've asked the Office of Medical Investigator to give us a sense of what might be going on in 2023. And I don't think the number is going to go down, and it'll probably be at least a little bit higher than 2022 and 2023. But it may not be as high as it was in 2020. Nationally, young people are also dying at a lower rate than they were in the previous years, which is a great change in trend. Nationally, there was about a 9% decrease in youth suicide in 2022. That's not true for all ages, though. Nationally, we're seeing increases in suicide deaths among older adults. And in fact, there will be more overall suicides in 2022 and maybe any previous year because of the effect on older adults and other adults. In New Mexico, we had about, I think, less than 1% decrease in our overall suicide count in 2022 compared to 2021. But we'll keep sharing this data and making it available as we get it. I just want to spend a minute just acknowledging that as long as I've been here, when we look at our surveillance systems and think about young girls and women, they often present with disparities in their mental health concerns. About 3 out of every 5 high school girls reports persistent feelings of sadness or hopelessness. About 1 in 7 reports a past year suicide attempt. While girls are less likely to die of suicide, we also see in the emergency room that there are many more ED visits for young girls with mental health and suicide attempt emergencies. And when we look at differences, say during the pandemic and stuff, it seems that young girls may have been more likely to experience mental health concerns than boys during those times. Someone put in the chat a question about the decline due to many parents that transition to remote work schedules from COVID and since. It's a really hard question to answer. I think, I started being an epidemiologist in 2020, and everyone wanted to know, well, what's going on with children during COVID and their mental health. And in the years since, my best guess is that there were kind of winners and losers. Like some people, I think, did, like you said, because parents were home and maybe spending time with young people and their stress level may have been lower and they might have had time with their children, that the net family mental health effect may have been very positive. But then there may have been other families where they weren't able to remote work and it was a huge, stressor and challenge on the family. When we have this sort of like, we call them like bi-directional effects, where both like a good thing and a bad thing happens at once, it can kind of wash out a chart and make it look like there's no change. But the real story might be that, some people benefited and some people were harmed. But I think we'll continue to learn more and more in these sort of years that we're in now about what happened during that time. But yeah, it's a real question I would like to know more about that you put there. This is just to kind of highlight some of the data that DOH can put out. Looking at the fall semester of last year, looking at July to September, and the number of suicide-related events. So this is when a young person is diagnosed with either like a suicide attempt or ideation. We saw that girls aged, I think this one's 12 to 17, 5 to 17, had more than double the number of ED visits in the month of August for suicide-related issue. Does anyone have an idea of what maybe happened in August of last year, or what happens in August that might be a stressor or a trigger in the event?
School starts.
Yeah. So this is one actually outcome is really related to the COVID questions, and we started looking at a lot of like seasonality and the time effects. And across the country, we're seeing that these months when young people return to school, even like return from breaks and stuff, are times when there's spikes in mental health emergencies, and particularly among young women, young girls. And it's not just in, some of that is probably due to the fact that schools may be initiating a call, but we also see suicide deaths higher in this time, and they're much lower, the lowest in the months of June and July for children, which happen to be the times when they're highest for adults. Yeah. Just wanted to spotlight a couple other just things that we've been talking about that we think are related to mental health outcomes. When we talk about suicide, we know that many young people who in New Mexico who die from suicide use a firearm. We review individual deaths of children who die of suicide by reviewing their history and what's known about them. In many cases, a parent didn't think their child was at risk of suicide or didn't know. And we wonder if the child might have been like impulsive or reacting to like a temporary emergency, and because a gun was available, that there wasn't really an opportunity to intervene or slow down and offer support. When we talk to adults on the phone, the adults that have firearms in the home, about 1 in 7 households will say that not a firearms and a child in the home. They'll say the gun is loaded and you don't need a key or combination to get it. I think that's just important in thinking about the kind of level of risk there might be for young people who are thinking about suicide or self-harm, and recognizing that there's probably some room for education for gun owners and stuff around just security and what risk lies there. At least for me personally, I just would like to go to less of those meetings if I can help it. They're really powerful and important, but it's frustrating. I always feel for the families after their losses. We do collect some information, but not enough, around resilience and protective factors. Just want to acknowledge that these really matter. When we ask young people if there was a parent in their home where it was very much true that that parent or some other adult believes they'll be a success, these young people were much less likely to report a past year suicide attempt than other students. Thinking about social media, I think when we look at those trend lines and think about, like, say, well, what was going on 2015-14 that might be changing youth mental health? A lot of people think social media and online time may be a factor. We really have not well imagined this in our surveys of young people. We know now that about 40% of young people are spending 5 hours or more on a school night, not including school activities, in front of a screen. When that question was written, that was like the highest number a person could have imagined a child would say that would be the answer. And it wasn't a common number 10, 20 years ago, but now that's a very common outcome. And it is associated with higher risk for mental health concerns. I will say that this isn't the total answer. We know that social media really has positive and negative effects. We know that many communities, say like American Indian, Alaska Native youth or LGBTQ youth or other adults, are able to connect and communicate with people on social media that would be challenging to do in traditional social gatherings, and they see some positive effects from them. And so I just think this is an area of where hopefully in future years we'll be able to get better answers to what's going on. It's really important. We also know that when there's teachers or school staff who are supportive of young people, that we see reductions in risk for attempts. And I could also put any other mental health measure we have there, they all drop when we have supportive adults and young people around. I want to put a couple slides about adult mental health, and maybe just highlight some things that I think are interesting, maybe thinking about generational effects. Some of you might be familiar with the Adverse Childhood Experiences study that Kaiser and CDC did in California many years ago. In New Mexico, we included the ACEs questionnaire in our adult telephone survey. And so what you're looking at here is a comparison of adults who said that as a child, they lived with someone who is depressed, mentally ill, or suicidal, versus those who did not. And we just see that those people who lived with an adult who had those issues are significantly more likely to have all of these risk factors. Not that everyone has them, but they're more likely to be involved in binge drinking, smoking, to experience frequent mental distress, more than 3 times as likely to have been diagnosed with depression, and more than 4 times as likely to have considered suicide in the last year than other adults. I think there's a couple takeaways from here. One is recognizing the effects of trauma and harms over time. And also thinking about when we're supporting mental health, I think you mentioned you're doing like family to family groups and stuff, but I think like that's an effective strategy that relates to this, thinking about how families and structures of people affect people's mental health over time. I think those types of approaches are more needed than ever. So also spotlight that we started collecting some new data where we asked adults about social determinants of health. We asked more than these ones, but I'm going to highlight a few here. So we asked if adults felt like they were socially isolated and didn't have supports from other adults. About 1 in every 3 New Mexico adults report social isolation. When I did a comparison of us versus the other states who included this question, we had the highest prevalence of social isolation of all the states who did this module. And so thinking again about mental health, thinking about inclusive environments and spaces where people can join and learn about health and be involved as regular community members is probably a very important mental health intervention. We also know that many adults, about 1 in every 5, report that they don't have the emotional support they need. About 1 in 6 adults reports that that there was a time in the last year where they didn't have enough food and they couldn't afford to buy more. And about 1 in 7 adults report that there was a time in the last year where they couldn't afford to pay their rent or mortgage or utility bills. And so, these are really key issues that underline a lot of health issues. We can show just a couple slides that really say the same thing, but it's just that when we compare the people who had these issues with social determinants of health and their mental health outcomes among adults, it's just a huge disparity. Really, when we look at especially that far left bar, the considering a suicide attempt, almost every adult in New Mexico reports considering a suicide attempt also has at least one of these issues, in particular the social isolation one. But they're at much greater risk for mental distress, being overwhelmed with stress, or considering suicide. So this one we're looking at by food security, again, major disparity when people are food insecure. This is that issue when people can't afford their rent or mortgage. It's probably a greater stressor, and we see a greater disparity in risk for mental health concerns. And then here's social isolation. Again, almost every adult who reports considering a suicide attempt, I think something like 80% of them also reported being socially isolated. So kind of back to that topic of what does it mean to do prevention and what would a healthy world look like? It's maybe how do we address those issues around isolation and who's isolated and why? So let's look at the clock. It looks like there's about 13 minutes till the end, so I'm just going to probably pause on a slide that has some information about how to get info, but I would love to hear questions and try and answer anything I can. We provide a lot of this data on our Mexico Department of Health mental health page, but I just really appreciate all of your time, and I like to learn from you all. So if you have questions, please put them in the chat or comments, or just raise your hand or just unmute. Yeah, go ahead. I see, Donald, it looks like your hand's raised. Go ahead.
I work in one of our EDs here in Rio Rancho, and I have some, concerns just from our day-to-day intake of behavioral health, patients and what have you. One primarily, a lot of our EDs aren't, realistically set up for mental health. We do the lockdowns of the rooms, we do the safety checks, we do all the process, clear them medically and stuff like that, and then await for an eval. Most of the time, the eval is done by a clinician via video, which, in my honest opinion, is very impersonal in the sense that, if you're like in therapy or what have you, and, if there's any in the room, here tonight, you miss a lot of the interaction with said patient, in the questioning, body language, stuff like that. Kind of like we're watching a Zoom right now, and we only see each other from basically the shoulders up. There's missing a lot of key things, and oftentimes we'll either discharge or, depending on the situation, find a source. we've been seeing a lot of, you know, grade school kids from basically 7 years old on up to middle school, early high school. Not too many in the high school range per se, the elders. Um, so, and speaking, I see a therapist myself every 2 weeks. I think it's important for us. And I had this discussion with her last week. What can we do? Because, we don't have a lot of resources locally for kids, for one thing, especially in Sandoval County, kind of minimal in Bernalillo County. We're either sending children down south to Las Cruces, what have you. How do we fix that, and how do we make it more personal? Because also too, from an adult standpoint, when you do a Zoom meeting on somebody trying to, that's going through a true mental health crisis, I mean, it makes it a little bit impersonal when somebody just kind of looking at you and going through the check marks of everything and trying to, come up with a reasonable evaluation that then gets forwarded up to the psychiatrist.
Those are critical comments. So I used to be a social worker who would work with people in crisis often, and I relate to a lot of what you said. In particular, it felt to me like emergency rooms do well what is not well for mental health. Like, I feel like people in crisis sometimes need things to be slowed down and have patience and really be present with them, which is not really what the ED is often about. It's about, like, quickly triaging and moving through decision making. I think
Right. I mean,
yeah.
for instance, last week, we had an incident where a patient was able to get out. I mean, it's not like, they're in a lockdown space, kind of like the CDU that we have, at Caseman, once they get medically cleared and they go into that transition point. And unfortunately, this individual got hit by a car and later died. And I myself, 2 weeks ago, and I got fussed at about it, someone got out, and I have a personal accountability and responsibility to care for that patient, whether or not, I chased him and I actually got him to come back. So I mean, our ERs, I mean, and like I said, discussing this with my therapist, I mean, there's so many pieces to the puzzle and so many ways that we need to isolate certain things down, because again, like the one individual just mentioned, office space is expensive. And I was almost thinking, if there was a way, kind of like we have the UNM consortium of docs for like trauma related, field related situations. If we had a consortium between UNM, Loveless, us, and had that mental health outreach somewhat readily available, because again, we're isolating people and, they stop doing evals at 11 p.m. And we have people that, are struggling and, stuck until the next day in an ER.
There are good models and guidance on some of these questions. So depending on sometimes on topic specific. So for example, there's first episode psychosis programs, which work to like help people. So if they're identified in an ED or something with psychosis, that if they're young and it's their first time, that they really try and connect them with like really high quality outpatient care and supports and as soon as possible. And try and give them like occupational and social community supports, because many of these people are very successful when they get these supports early in identification. And that requires strong relationships with hospitals. There's a program that NMDOH has done that I've really wished we could try and find a way to connect to mental health. That is, they look at ED visits for like if young people have had multiple asthma emergency department visits, and if they've had like 2 or 3 in a 3-month period, then someone who's contracted by DOH will like, call that family and schedule like a meeting to go to their home or in person and sort of like just try and make sure that they've really been offered genuine access to like the supports we know work. And just regardless of what the ED does, try and find a way to follow up with these people and meet them, maybe at a time when they're not in an emotional crisis, to figure out what options there might be and what supports there are. That's a thing that's technically possible, that's not happening and would require, legislation and funding. And there are a lot of good mental health programs that I think really try and respond to crises in the community at the level of community and not rely entirely on emergency departments or 911. I know we're short on time. I just want to look at the questions. Let's go to Noreen, and I see a couple in the chat.
Good evening. I'm Noreen Kelly, and I am a certified peer support worker as well as a crisis counselor. And I am from Church Rock, New Mexico, just outside of Gallup, New Mexico. And just listening to this presentation, I'm beginning to validate my thoughts of we have to go to them. We can't expect them to come to us anymore. And we have to find ways to get out there in order to validate how our young people are feeling and let them know that people do care. We do care that they are able to rise above their mental health status at the time, and that give them tools, but provide them tools so that they can bounce back. Resiliency, the way I understand it, is you bounce back from whatever is ailing you. You may have a cut on your hand and it heals and you're able to use it again. Mental health is not too far from that. We have to acknowledge that our kids, our young people are feeling these and they do not feel validated. And the longer we do not get there, the easier it is for them to harm themselves. Thank you.
That was pretty powerful. And probably, I agree with you. Is what I want to say. I think your organization and peer and family-led organizations have long pushed this discussion out of shadows and helped many people. And I think you're really important what you shared. So I also want to acknowledge too that what you shared, Donald, too, like from my end, just thank you for doing what you did. I know that it may be thankless, some of the stuff you talked about doing, and you can't save the whole world, but in the absence of the systems we deserve, what you did that day really mattered and may have saved a life. So thank you for sharing that. I saw a couple of questions in here, one about 988. So from when I looked at 988, what we saw in June, July of 2022, when it rolled out, there was a fair amount of press and attention, and they received about like 2 times as many calls as they had ever received in those early months. But their numbers have gone down a little bit monthly since then, and I think are returning a little bit closer to what the NMCal had before, which gets me a little bit worried that we need to be doing more about really continuing to make sure people know about 988 and that they're utilizing it. If people are interested in looking at data, New Mexico Crisis and Access Line puts out monthly utilization reports on their website. So you can just look up how many people called a couple of months ago, what they were calling about and where they were calling from. And they have really detailed reports on that, really good information. Someone talked about pediatric patients and the lack of school counselors. There's always discussion of this. In fact, the legislature has a bill this year that I think is proposing to add something like $200 million to fund school counselors. The people I talked to at the Behavioral Health Collaborative are probably primarily focused on this issue, among probably the drug overdose issues also, but this is a major area. I think a challenge with these things is they're so logistical and the scale is so high that even if we do the right steps, it may take us 5 or 10 years to see the benefits of them. But you are absolutely correct that there are too many schools that don't have professionals in our, and I know that my colleague who works with schools now, Lesson Health, and provides training to them is, doing a lot of training on paraprofessionals, getting those like coaches and, the janitors, the people who work across the school and are interested in mental health to have some training to provide support, which should not be our first line, but it's another area where I see work happening. There's also a push by CDC and by the Public Education Department in New Mexico to promote social emotional learning programs, which may help, young people develop social and emotional skills that should carry through their whole lives. There's a lot of evidence that that works. That would be something that will probably help a lot, but we won't change our ED visits for adults for 10 or 15 years, but may make a mark. Yeah, so tribal data is an interesting topic. We actually hold a lot of tribal data, but tribal sovereignty means that we need to work with tribes and give them sovereignty over just releasing data that's specific to tribal communities and areas. And many tribal epidemiology centers have been underfunded and struggle with keeping up with the requests they get, which is another way that I think tribal communities struggle with their own health data and outcomes. It's a good comment. I know we're probably at about exactly time. I want to pass it over to Jessica and Jackie if there's anything else. I'm happy to hang out though if there is time to keep talking. I really appreciate you all. Thank you so much.
Thanks, Dylan. There's just one more question in the chat. Are there plans in New Mexico to attract more mental health care providers? I didn't think you saw that one, especially for pediatric patients. There are schools in New Mexico that don't have counselors on their campuses.
Oh, another thing to mention about that is there's a UNM program called, I think it's like Access to Behavioral Care, Pediatric Care, NMABC is the acronym if you Google it. But they're providing free trainings and supports to like primary care physicians and other professionals and paraprofessionals across the state in identifying, treating, and responding to mental health issues. There's a lot of pediatricians who get these cases and don't know what to do. And so, I think they would probably have a lot of insight about that topic. Every year I see bills. I think there's also a bill in there about offering free college this year for people who are getting a mental health profession. I don't think it's going to pass from what I can tell this year, but there are legislators who are trying to push issues that would change that trend. And so those are things I think to highlight. But yeah, I think your voices and your work matters for those types of pushes too.
And if you send me your slides, I can email them out to everybody. And also there'll be a recording of this video available in about 48 hours or so that I'll send out as well.
Perfect. I'll send my slides as soon as we end. Thank you.
Thank you. Thank you so much for being here with us. We really appreciate it. Do you have anything else, Jackie?
Thanks, Dylan. It was good to see you again. And thanks for all your good work and tracking what's going on in our state.
Thank you. Hope to see you soon. Bye.
Thank you, Dylan.